Anything else? Okay, so let's move on then, thank you. We will now turn to some feedback. So we want, and I hope people are going to give us some warts and all, not going to say what we could improve as an auditing and accreditation process. So we have some speakers who are going to give some feedback to us. First of all, I'm going to invite the chief executive of a cancer center that is the furthest away, undoubtedly, in Santiago in Chile, who were accredited a year ago, to give us some feedback. And then I'm going to invite Stefania Gori from the center near Verona, called Negra, and finally Leonie Young from the Beaumont RCSI Centre in Dublin, to give us some feedback in 10 minutes each of what the accreditation process has meant for them and for their centres. So I invite the first speaker, Cristian, to come and join us, please. Cristian.
Thank you.
Hi.
Hello, hello, hello. Yes. Well, I'm Cristian Ayala, the CEO of Fundación Arturo López Pérez. The acronym is FALP. And I'm very pleased today to share with you how the accreditation process has helped us to improve. Yes, we'll talk a little bit about Chile. Chile is really in the south of South America, and it's a very thin and long country. It's 4,200 kilometers. So it's equivalent to the distance from the north of Sweden to the south of Greece, so very long, no? And we have a 20 million population. We are really a middle-income country, and we have a modern capital that is Santiago, which is a very busy capital. And we are really a centralized country, with the Santiago region having 7 million inhabitants, and that's where we are located. The FALP was founded really by Ana Ros, which is the widow of Arturo López Pérez, that's why the name. And the mission that she gave this institution is to provide a comprehensive and excellent care to cancer patients, especially to the most unprotected, along with promoting cancer prevention and fighting it by all means. We are a not-for-profit private foundation, and really for us it's very important, this part of the phrase that says especially the most unprotected, because this country have a private and public insurance and provision, and really have big disparities. So for a big part of the most poor population, it's really hard to access to cancer care. So having us giving that access is a big challenge for us. No? And within the years, we have developed what we call this social healthcare model that aim to solve this access problem. And we really today have 5 areas in the Institute. We have the Cancer Institute, where the reference cancer center in Santiago and in Chile. We try to bring comprehensive care for the patient. We have a research and education area. We also have a solidarity fund that gives financial coverage to 1 million people in Chile. They pay us €9 a month for that, and that helps a lot to bring access to that population. We also have a charity operation. We have 50,000 people that donate us in order to give access to the most unprotected people in Chile. And we have an education and prevention operation also. We really, as Simon said, we are the first Latin American country to be accredited as an OSC cancer center. And this journey started in 2019, really quite some years ago. But we start with the firm belief that integrating OACI best practice was really impact the quality of the patient. We really think that we didn't start this thinking that it would be good to have the name of OACI associated with us, but that we're really thinking that the pathway that this accreditation is structured will really help patients. So really that was the spirit that we enter into this project, and we have the commitment and involvement of the entire upper management, from the president that is here, it's Alfredo Comandari, and all the board within the institute. Really, we did our own gap analysis in 2019. I will show how the score went there. We're not great, I will anticipate. And then we have the COVID years that were very rough, really years, and we feel that we were ready for the process at the end of 2002. We have the go decision from the OACI in February 2023. We have the visit in March, and we have the accreditation in September. And really, it was the numbers. We have a 33% compliance in our own analysis in 2019, so we have a lot of work to do. And when we received the peer review of auditors, we really get to 77%. And more than details, I would point that the main gaps were in research and multidisciplinary teams. And research, I would say, but because historically, we'd be much more a clinical cancer center focused on giving this access, but not a university center. And in multidisciplinary, we've been working with tumor boards all along for several years, but we didn't have the process of clinical pathway, which was a big challenge. I will go through each chapter just to mention a couple of things in each chapter. In governance, we did a whole new strategic plan for the whole institution and also for the cancer, for research, and every other area. We also do the adoption of the objective and key result method, establishing yearly goals and quarterly review in order to progress that, to review the progress of the strategy. In the organization of quality, we really established a new quality improvement and risk management department with this view of being proactive in the risk assessment and prevention that we didn't have. We roll out quality and safety dashboard for every other risk that we thought was important. We worked very hard in the tumor registry to have 5 years in a really good state when we applied to the accreditation. And we also started having monitored very close and very, I would say, comprehensive panel for latency. That was one of the issues that we have in the center. In patient involvement, we created a department of empowerment and participation. And the first task that they did is they implemented the patient council, their picture of that, founding that council. And they've been helping us in different projects during this year. In the multidisciplinary, I would say that this one of the toughest, I was a standard that we didn't have. We worked through the COVID years in doing so. We do it for 49 cancer pathway. And really now we have developed quality indicators for each of the multidisciplinary teams, and we're measuring adherence of the patient to this pathway nowadays. In prevention, we established a department. We have some initiative, but it was in different areas within the cancer center. We combined it in a department, and we start doing more things. We start this early detection program for patients, something that the OSCI recommends us strongly. And we also launched an internal and public no smoking campaign that is a picture with local authorities. And the second picture is interesting because it has the internal campaign. The one is one of the leaders of our unions. She quit smoking in the first campaign, so in the second campaign, she's the face of the second campaign, the internal campaign. In diagnostics, we formed the molecular multidisciplinary team that we didn't have, and we deployed NGS panel for hematology and solid tumor. We're working with MCI sequencer. We send the physician to Catalan Institute of Oncology for further training, and we're working with online platform for the classifications, for the interpretation of the results. In treatment, we developed the advanced practice nurse role that we didn't have. We're just starting on that. It's something new to the country also. And we established the survivorship program, and that we communicate to the whole community, including one of the main newspapers in Chile. We send an article so people start to know this program really in the community. In research, there's one of the toughest things also that we're behind. We established our research department. We have some coordinate, like functional areas that were in charge of this, but not a formal department, so we did so. And we also formulated this cancer research strategy plan. We developed a translational research laboratory, an epidemiology unit also. And I would say that the most long-term thing is really to foster this research culture within the institute. So not only the people that are full-time dedicated to investigation, to research, do the research, but every other department within the institute. And that's something will be long-term kind of effort. The number of publications has been increasing, the impact factor, but we feel that we have a long way to still working in this area. And in the last chapter of education, we also established an academic department. We have new fellowship programs in surgery in particular, and we are working, putting effort in the digital platform of e-learning also. And just to point out as the main things, I would say to wrap up the presentation, we really developed several new areas and processes in order to address the gaps and align with the OSCI best practice. We also implement quality indicators, benchmark for monitor continuous improvement. And we really change our mindset in terms of being really anticipating the risk and mitigating the risk beforehand they occur. No? And also we have this long challenge of promoting research culture within the institute. And I would say, as a whole, the accreditation have had a profound impact in the center, and we really think that we have, of course, a lot of work to do, and we hope someday we'll become a comprehensive cancer center. Thank you very much.
Thank you very much, Cristiano. That's just wonderful to see all that progress in a short space of time, and really huge effort. So now I invite Stefania to come, please, and tell us about your experience in Negrar, near Verona.
Good morning. Thanks, Dr. Obers, Dr. Burion. Our hospital, Negrar Hospital, is located in Italy between Milan and Venice, near Verona, the city of Juliet, and specifically in Valpolicella, a valley famous for Amarone wine. Our institute is a general hospital with 940 beds, and due to the remarkable oncological activity, in 2021 it became a member of ACC, the network of Italian oncology institutes founded by the Ministry of Health to coordinate cancer research. In 2023, we received the certificate of the Cancer Center from OECI after an accreditation process and a site visit in June 2022 coordinated by Dr. Burion. The accreditation process has resulted in improvements in the organization of the Cancer Center, in the quality of care and education, in the cancer research, in the implementation of cancer prevention strategies, and the patient's involvement. In organizational setting, we established a board of the Cancer Center in June 22, and the board started its activity in October with meetings every 2 months. The board of the Cancer Center represents a very important link between the board of directors of our general hospital and the Cancer Center to improve the oncological activity. Indeed, in our general hospital, the Cancer Center is an identifiable entity, but not a legal entity. This slide shows the composition of the board, coordinated by the medical director, and its functions: definition of the budget for cancer activity, definition of the strategic plan of cancer care research and education, and the annual monitoring of these activities with the identification of key quality indicators. The board of the Cancer Center developed the strategic plan of the clinical and research areas for 3 years and assigned to each clinical unit its specific objectives. In terms of quality of care and education, we recorded these improvements: upgrading in technology, improvements of the organization, multidisciplinary teams, and specifically with the revision of our electronic patient record, as reported in this slide, and according to this OECI indication. Minutes available within 24 hours from meeting, record of any deviation from the guidelines and the regular evaluation of these deviations, and indication of patients included in clinical trials. Moreover, we organized intra-teams and inter-teams meetings to review the activities and the issues for this year. After institution of the position of a case manager nurse and the organization of meetings on specific tumors in 2023, the inclusion of a case manager nurse in some multidisciplinary teams is in progress. In 2021, we established a palliative care team to improve the quality of life of cancer patients to support their family members and caregivers, and the building of the hospice with 10 beds was just completed. Training and continuing education meeting for professionals, including nurses, have been planned as reported in this slide. And about data registration, to date we have a database for breast cancer, and we plan to create databases for other types of tumors necessary to also evaluate the outcomes of our patients. Our improvements in cancer research are reported in this slide. The board of the Cancer Center established the internal scientific committee in 2023, and the committee started to evaluate our spontaneous clinical trials. The biobank building has been completed, but other activities are in progress. Moreover, we reorganized the research offices with the identification of the Clinical Trial Office for relations with the Ethics Committee, the Grant Office, the Statistics Team Office, and the Data Manager Team Office. The board of the Cancer Center identified 4 research groups covering basic, translational, and clinical research, as shown in this slide. We are also intensifying the collaboration with the national research groups and with Italian university for postgraduate training and for the institution of some PhDs. We obtained an improvement in publication numbers and in impact factor. The training activity on the methodology of clinical research continues with the School of Negrar. To date, we have completed 10 annual courses with the participation of about 600 Italian students. As regards cancer prevention strategies, the activity of the Anti-Smoking Center began in February 2024. In Italy, patients' involvement within decision-making boards is still not as widespread as in other European countries. To give certified information to patients, we have produced the notebooks on the different types of cancer in collaboration with ROPI, the Italian Network of Oncological Patients, because our institute is one of the founding members of ROPI. The notebooks are written by professionals, about 150, including nurses, together with patients, and are available also online. We have organized some conferences dedicated to patients and the patients' associations, and we have started collaboration with some patients' associations. We have also organized the training courses for patients to be included in the working groups of Italian regional oncology networks. For some years now, we have organized the Federica Literary Award for Cancer Patients, dedicated to Federica, a young patient you can see in this picture. However, we still have a lot of work to do to include the patients. The last slide recaps the most important improvements achieved in our cancer center with the OCI accreditation process, a very important opportunity to improve and develop our oncological activity. Thank you. Thank you.
Thank you very much, Stefania. That's wonderful. Lovely to see again some amazing improvements over the last few years in your center. And now it's my great pleasure to invite Leonie Young from the Beaumont Cancer Center. Yes, this kind gentleman will come with the Taylor Swift microphone. And why are you up, Leonie? Is this okay? Yeah, perfect. Oh. Not a Taylor Swift, you have a handheld.
Rockstar.
Thank you very much indeed.
So firstly, I'd just like to say a huge thank you to the organizers for inviting us here today to describe some of the improvements that have come about thanks to the OECI and the accreditation process. So this is us, a small island at the very west, which definitely gets the worst weather in Ireland. And we are based just outside Dublin, on the north side of the city, which is a particularly socially deprived area. And this has really driven an awful lot of the types of research that we do and in terms of our clinical care. So in 2019, we set up our cancer centre. And I'd like to point out that this is a very easy breezy organogram of our structure, which nearly killed us to put in place. As we alluded to before, setting up a cancer centre within a university hospital represents a huge challenge. So our cancer centre brought together our university hospital, Beaumont Hospital, the Royal College of Surgeons in Ireland, but also St. Luke's National Radiation Network. So it was a complex structure to bring together, but once it was there, it was very powerful. So we have a cancer centre board which represents the CEOs of both the hospital and the university, and also representation from our radiation network. Apart from that, other members of the board include the non-executive members, of which we have 2 patients, and outside expertise, both in research and in clinical care and in governance. And also on the board sits in attendance all of the leadership from both the Cancer Executive and the Cancer Research Executive. Both these working groups are really informed hugely by our Patient Partnership Working Group and also our Scientific Advisory Board. So this is where we are in our journey. We set up in 2019 and then went towards accreditation process in April 2022. We have travelled our journey since then, and I'm going to share with you some of the things that we have tried to focus on, which was really based on the site visit that we had from the OECI. And here we are up in, Here we are up just after April 2024, and we've just finished an entire review of our strategy with the executive, and we're due to bring that to the board in about 2 weeks' time. So in preparation for today's talk, we did a survey. So we surveyed everybody in the Cancer Centre, from our patient partners to our oncologists to healthcare professionals, and asked them what they considered to be important in terms of the OECI process. So what did the process do for them, or what did they consider? So our accreditation lead, known very well to all here, sent out this survey, and we got actually a phenomenal response. And Irish people are great at talking, but they're not great at filling in forms. So we were really impressed. So this is some of the things that they shared with us. They really liked the fact that we, for now, had direction. We had a pathway on which to travel. Everybody likes a plan. They liked the collaborative quality of our improvements and the fact that it was completely multidisciplinary. So we were bringing everybody together to try to make life better for our patients. And we were working towards a common goal. They had a really feeling that it wasn't a tick box exercise, that we were brought in together. And that we also helped to establish our reputation. And often we felt kind of like, not ignored, but the poor cousins of research science. When the accreditation visit happened, there were many things that were brought up, many things that were complimented, many things that were sought for improvement. But one thing that was closest to our heart was that we were found to be very patient-centric, but not patient-partnered. And I think it actually took a lot of reflection in our cancer centre to really understand what that meant. And I think that if we've gone on a journey to do anything over the last couple of years, this is probably what's closest to our heart and what we're proudest of. So we've really worked really hard on this, and many people in the room here I know have travelled a very similar journey. But we've really made an effort to involve patients from our governance, they're on the board, right through all our structures, and from anything that anybody takes a pencil to a piece of paper to try to start to plan out some research, it's shared with the patient right through to the outcomes of that research. In terms of clinical care, these are some of the issues that we have focused on following our site visit and since that date. So we've expanded our cancer database, and this includes not only times to treatment, times to diagnosis, but also out the other end, which is much more tricky, as in outcomes. We have a real-time dashboard with newly diagnosed and treated patient data, and this has really empowered our way of thinking, our planning, and our not only in terms of patient care, but also in terms of research and research trial activity. We've put a huge work into multidisciplinary structures, not only MDMs, but the idea of MDM being absolutely whole. So pathologists, radiologists, oncologists, absolutely, but also research scientists, students in training. So everybody comes together so that not only is it good for the patient, but it's also a huge learning opportunity. We've established annual audit cycle, and also we've set up MDM team leads meetings where that they can learn best practice from each other and share it not only throughout our community, but also nationally. We have put a huge amount of work into our patient pathways. So we've a collective process for coming together to document and formalize these pathways. And now we have 2 consecutive years of these pathways in terms of newly diagnosed and newly treated patients. And indeed, we have just started a clinical trial to look at the power of this and to look at the power of sharing this information with our patients. So do our patients do better in terms of their outcomes, in terms of how they feel about their treatment strategies, if they know what their patient pathways are going to be and how that they can contribute to those? Research, closest to my heart. So this is our Research Advisory Committee, and they've been really carefully selected, not only for their sense of community with our research centre and with our cancer centre, but also for their various expertise. Felix Fung is a radiation oncologist, and Alistair Thompson is actually a surgical oncologist. I know, really rare to have somebody so involved in research, but he's from Baylor, and he's really, really helping us transform our clinical surgical trial activity, which is really nice. And again, our patient partnership working group, also both of these hugely important groups feed into our research strategy, help us reflect on the research that we're doing and look at our outcomes. So this is the way we've set up our research within our hospital. So we've set it up in disease groups. So every cancer centre has the things that they're good at and the things that they're probably not so good at. But what we've done is that we've set up our research groups to reflect our clinical groups, so that when we're reporting back on not only the amount of patients that we've come through, the amount of newly diagnosed patients, but then we can also transfer that out the other end in terms of the amount of observational trials that we're doing on these patients and the amount of interventional trials that these patients can be recruited to. So you can see that they're hugely multidisciplinary. Everybody here is representing a different type of discipline, whether they're a basic researcher or a clinician or in diagnostics. Over the last 10 years, we have put a huge amount of focus on biobanking, or what I like to call clinical translational trial activity, because I consider it to be so much more. If you gather information properly from your patient, you track them, you track everything about them and all of their outcomes and their treatments. It's a huge resource that enables you to do the type of molecular and genetic biology that allows you to do investigator-initiated trials at a much higher level. So where we have put all of this work in, we are now starting to reap the benefits of such a rich resource. So all of our translational trials are registered as full clinical trials with all the rigor that that entails. And we currently have over 4,000 patients on open observational trials within our cancer centre. So we are also pushing all of our biobanking activity through ISO accreditation. We have gone through the first part of this process, and we hope to complete that by the end of June this year. We will be the only second cancer biobank within Europe to have full ISO accreditation, and this gives our biobank a huge amount of standing. Clinical trial activity has always been a challenge in Ireland, and we need to face that challenge head on and try to do everything we can to make it better. But we believe that clinical trials should not just be pharmaceutical interventional trials, but can be multidisciplinary and diverse, from surgery through to enhanced observation. So we've come a long way, thanks to you guys and a little bit of competitive spirit. So from 2020, when we had just over 30 clinical trials, now almost 50. And we can see that we're also diversifying along our disease groups, particularly with the new recruitment of hematology and lung specialists onto our team, which have made a huge difference. In terms of our outputs and reporting, this has also improved over our time with the OECI. So you can see with just 150 publications in 2018, this has grown to almost 300 now in 2023. And we've also improved the quality of our research if impact is a measure, and we expect this to grow ever further over the next number of years. We are trying to be strategic and build programs that matter to our patient population. As I mentioned, we were in North Dublin, so smoking would be a large part of that. And we have recently had a large award from the Irish Cancer Society to run a lung health check program, which is really good, where this goes out and is CTs out in the community, measuring and diagnosing patients early and bringing them in for early interventional care. In terms of national networks, we now house our National Clinical Trial Network and have received large government funding to help us roll this out. And I really think that this will help us improve our clinical trial reach, not only within our own hospital, but also enable us to be leaders nationally. We also have got a recent award just in the last week to look at our patients with breast cancer brain metastasis. We are the neurosurgical centre in Ireland, so every patient with breast cancer brain metastasis comes through our door, and this programme will allow us to profile them from primary diagnosis right through, not only at DNA mutational level and transcriptomic level, but also at DNA methylation level, which is often an unforgotten hero, I think, of the changes that we see as patients progress from primary tumour to metastatic burden. And these patients are very, very poorly served with lifespan of less than 12 months. And finally, one thing that isn't in the standards, and I would profess maybe ought to be at some stage, is innovation. It's very difficult to get scientific discovery through to the clinic without innovation, without protecting IP, without making it attractive to industry, either to partner with you or if you're brave enough to set up all by yourself. So we've recently partnered with the Government Science Foundation Ireland, ARC. I cannot take credit for this on our own. This is actually led by Trinity, and I see the co-director of this programme in the audience, Liam Gallagher. But this type of initiative is huge, and it'll really transform in Ireland the way that we do our science in terms of therapeutics and the way that we bring it forward. So that is us. And where we are today. These are two of our research reports, and we also have a clinical report that we have put out over the last number of years, really just detailing our achievements to date, and also hopefully pointing out some of the things to remain to be done. So we hope to remain and build on our patient partnership program, because we really feel that that's the foundation of our cancer centre. We know that we need our multidisciplinary research to really focus on our core strengths so we can make a real difference, not spread it thin, but to be focused and clean and clear. We need to diversify our clinical trial activity and not rely solely on pharmaceutical interventional trials, because it will not be enough, and also it's not asking the big questions that are really pertinent to our patients. We need to strengthen our translational activity to drive innovation. If we don't have good biobanking facilities, if they are not clean, if they are not fit for purpose, then the information that we will be receiving for them won't be fit for purpose, and therefore innovation will not be possible. And then the last one. This is always going to be the trickiest, but it's what everything else is driving us towards, is to increase our patient recruitment onto our clinical trials so our patients have better outcomes. Just to say that the challenges really are the challenges that we all have. It's regulation, regulation, regulation. Unless we solve this, and I think it's particularly hard in Ireland, we will not see progress, particularly in our clinical trial activity. Anyway, thank you very much.
Thank you very much, Leonie. And I take on board very much that point you made about standards for innovation. And if you'd be kind enough with Liam as well to work with us, I mean, if we can actually improve those standards on innovation, it would be lovely to think that, for instance, pharmaceutical companies would look at centers who have an accreditation by OECI and say, well, that, particularly in the area of clinical research, that demonstrates that this center is really well organized and structured and efficient to be a platform for receiving clinical studies. So let's work on developing that. If we can improve those standards on innovation, we'd be very happy indeed to do so. So thank you very much for the feedback on those three very different centers in different settings, in different continents. What I take from that is that all centers are continuously improving. There's no doubt about it, we can see that. But that the OECI process is just one of the tools in the toolbox to help that process of improvement, to shine a light on what is working well and the gaps that there might be and things to improve. So we always say that perhaps the most important document to come out of the process is the improvement plan for the center. That's the really important document, and that is what spurs the continuous improvement of quality in care, research, and education. So thank you very much for those great 3 talks of feedback.